Dear colleagues, good afternoon. Welcome to this international session of the e-sfar meeting, this session on perioperative acute kidney injury. My name is Professor Thomas RIMMELE. I work in Lyon in Edouard Ayot Hospital, and I work both in the operating room and in the ICU. And I'm very happy today to chair this session. We are all very lucky right now because we're going to hear 4 of the best international experts in the field of critical care nephrology. I'm going to introduce them one by one, and we're going to start with Professor Max.BELL from Sweden. Just before, I would like to tell the audience that this is an interactive session, so I have the possibility to see all your questions on the iPad, so please feel free to send questions on the website, and I will forward the questions to our 4 experts. So let's start with Professor Max.BELL, who works in Stockholm in Sweden. Max works in the Department of Anesthesia and Intensive Care Medicine at the Karolinska University, which is one of the most famous institutions in Europe. So Max, during the next 15 minutes, we're going to tackle the epidemiology of perioperative AKI. Thank you very much, Max.
Thank you, Professor RIMMELE. It's an absolute honor to be here and talk to you Frenchies about the epidemiology of perioperative AKI. I too, like Professor RIMMELE, work both in the OR and in the ICU, even though I spend most of my time in the Karolinska ICU, but I do have a perspective of the perioperative AKI situation. I'd like to share with you my thoughts on this, and then I welcome your questions. So basically, my assumption is that, and I could be wrong, I'm often wrong, but most surgeons and anesthesiologists, they don't really care about perioperative AKI. It's just something that sort of swivels by. Somebody had an elevated creatinine, and people don't think about it that much. But I believe that we should care. AKI is common after surgery. And it is associated with clear increased mortality and long-term renal dysfunction, and also other morbidities actually. And not in all caps, but in small letterings, I've written there might be room for improvement, both preoperatively, intraoperatively, and in the postoperative period. I think we could collectively actually change this outcome and improve this outcome. So I'm assuming that you all know the rifle that turned into the Aiken, that turned into the KDIGO definition. It is important. I want to mention it, that we use the KDIGO definition to tell if somebody has acute kidney injury, and to stage it into stages 1, 2, and 3, where 1 is a sort of a light AKI, and 2 and 3 is worsening AKI. And there are possibilities in the future that we will challenge the functional marker, using a functional marker to define a kidney injury, which is what KDIGO does, and instead use novel biomarkers of injury. We still don't have a troponin T for the kidney, but we are exploring those possibilities. But we need to acknowledge the fact that Professors Kellum and others they made a very important decision back in 2003 or 4 to standardize the definition of AKI into the KDIGO definition. It has improved how we understand AKI, and it has improved the research. And newer biomarkers may perhaps be able to more quickly and accurately diagnose kidney injury, because it's a fact that if a patient has had a super fast decline in kidney function, it still takes a while for creatinine to accumulate in the body fluids where we measure it. So it would be nice to have a really quick marker of injury that could help us in the future. But the jury is still out on that, so there are a number of promising biomarkers, both measuring kidney and measuring perhaps recovery possibilities. But I've just thrown up two studies to show you that There are studies showing that, for instance, cardiac surgery AKI is not helped by TIMP2 and IGFBP7, which are promising markers. And another study from back in 2016 actually shows that it does predict kidney injury. So we'll see. But most studies that we have to look at the moment use functional markers. They use KDIGO or older definitions of AKI. So how common is this? And this is a slide from the ADKI-POKI joint meeting back in 2019, just pre-pandemic, where myself and others were looking at perioperative AKI, and these are fairly recent studies where you can see that the incidence ranges from around 2.9% until up to 39%. And in a more in an older review by Sunivara and Rinaldo Bellomo in Australia, unusual Finnish-Australian collaboration, they show pretty much the similar things. You know, we have incidence ranging from like 1% up to like above 30%. So, and this wide range in incidence, of course, mirrors the fact that we are looking at different patient populations, and this is dependent on what type of surgery one is looking at, and also the patient comorbid factors. And these two are obviously interconnected. So, you know, vascular surgery patients are generally associated with having more risks of or higher risk of AKI as compared, for instance, orthopedic surgery. And this is obviously, you know, due to the fact that you sort of usually undergo vascular surgery because of comorbid conditions that cause the need for vascular surgery, like diabetes and cardiovascular disease. And those two conditions, diabetes and cardiovascular disease, are interconnected with high risk for AKI. So this is not at all surprising. Cardiac surgery AKI is both a type of surgery where the risk intraoperatively and the time on bypass machine is very closely associated to risk of AKI, and also a patient population with a high intrinsic risk of AKI due to their comorbid condition. The RELIEF trial from Australia, which was a fluid RCT looking at restrictive or non-restrictive fluid therapies, it might be mentioned later, was looking at abdominal surgery. And this is a fairly recent publication, and it showed that the incidence was between 5 to 8%, dependent on the restrictive or non-restrictive fluid strategy. Of course, incidence is affected by intraoperative factors. I don't want to steal the thunder from Professors Kellum and Osterman following my talk. I would never do that. That's not my style. But so I need to just get it off my chest that incidence is in fact affected by intraoperative factors, and these are modifiable factors. So shifts in volume, like the RELIEF study showed, shift in volumes happen during surgery. Hypertension and how we treat hypertension might be a factor. Blood draws and transfusions could be a factor. And then there are surgical intraperitoneal insults, of course, compromising renal blood flow or indirectly compromising renal blood flow. We have the inflammation, surgical trauma. We could have patients that are exposed to bacterial leakage and or infection and sepsis and hypoxia. So these factors are good to know. And to finish off, how dangerous is perioperative AKI? Well, it's pretty bad. So there are old studies, mostly looking at cardiac surgery AKI, where every like 10% increase in creatinine is also associated with a higher mortality. But I've chosen to present two studies. One is a large single-center registry study of around 50,000 patients, showing that if you have patients who have no AKI or no CKD, that's like a 6% cardiovascular mortality. And then if you have a single organ AKI, no CKD, it's 11%. And then if you have a CKD, no AKI, 12%. Then if you have acute and chronic AKI and CKD, 90%, and then ESRD patients have even higher mortality. And actually, Professor Prowl, who will speak later today, he was the author of a systematic review that I've presented here, where you look at the short-term mortality in all-cause mortality in all types of surgery, and you look at post-operative AKI versus no AKI. It's a 12.6-fold increase in risk of death. So it's pretty dangerous, I'd say. So to conclude, we've had a problem historically where different definitions sort of distorted the comparability between studies. KDIGO and Aiken and Rifle before KDIGO solved that problem. That's good. Likely biomarkers will sort of add to our EPI tools, and they could also add to our pathophysiological understanding of what happens. There are different types of perioperative AKI. AKI is, as you know, a syndrome. But, again, real talk, between 5 to 20% of our patients undergoing major surgery, they will have an increase in creatinine or oliguria or both. That is AKI, and that increases risk for post-operative adverse events, including death. And to recognize these high-risk patients preoperatively is important because it allows us to optimize their treatment. And to find the modifiable factors is the paramount and big issue of our time if you want to be a bit dramatic. So with that, I thank you for your attention. I'm happy to discuss this with you. Thank you so much.
Thank you very much, Max, for this talk. I have a couple of questions for you. First, I fully agree with your first slide, underlining that most of surgeons and anesthesiologists do not really care about AKI, or at least they do not care enough, I would say. Do you have any idea why? Why is it like this? I mean,
I think it's a good question. It's odd. It's like I do feel that sometimes some of my cardiovascular surgical friends, the cardiothoracic surgeons, actually they've sort of slowly but surely grasped the fact that this is a bad sign. So they have, in my humble opinion, changed their minds, during the last 10, 15 years. But in other surgical areas, I do feel that this is something that just flies under the radar. People don't really care about it, and it has something to do with us. We who actually are kidney nerds in the ICU and or in the OR, we need to inform our surgical colleagues that this is a major adverse event, and it actually impedes the recovery of the patient. I just think we've been not good enough in sort of enlightening our surgical friends about the need for detection of this syndrome. That's my sort of feeling.
Okay, Max. So in France, before every single elective surgery, we have this anesthesiologist consultation, happening several days before, sometimes several weeks before. Do you think it could be the right moment to assess the renal function and to try to assess the risk of AKI during the surgery? I would think it could be a good time, but how is it in Sweden?
Yeah, we have the same procedure in Sweden. So certainly high-risk patient will come into the Karolinska pre-op sessions, days, 2 weeks ahead, and this could be a good time to actually improve our assessment. We usually focus on, I'd say, cardiac issues. You would detect a patient with hypertension and think about treatment of that, and you would maybe do a cardiac echo and to optimize the patient for the intraoperative session. But rarely you see the anesthesiologist and or the surgeons delve into the GFR of the patient. So this could be an area of improvement, I think. Again, I work, more in the ICU than in the OR, even though I do tend to the OR sometimes. But I think that this could be it's a good point of contact and a good point of attack, if you will.
Okay, thank you very much, Max, for this talk and these answers.